All right, good afternoon, everyone. I think we're going to go ahead and get started here. My name is Autumn Hassinger, and I am a board member and longtime member here at the PAMGMA. And I just want to say thank you all for joining us today. Just some housekeeping items. You do have the ability to turn your mic and your camera on. We do want to make this an interactive conversation if possible, but also if you're more comfortable with using the chat feature, please feel free to do so. I think as chat questions come in, we're going to probably hold off on them until the end of the section or the session, depending on how they apply. But to go ahead and kick things off a little bit here, today we have three great professionals joining us to talk through the 21st Cures Act interoperability requirements that are going into effect in July of 2021. First off, we have Matt Murin, the CEO and co-founder of True North ITG, a healthcare IT and cloud service provider. Matt is a cybersecurity expert with 22 years of IT experience, ranging from GE to Sony Entertainment, and an expert on the 21st Century Cures Act. His passion is bringing enterprise IT to small and mid-sized businesses through healthcare IT, cybersecurity, and cloud computing. When Matt is not helping businesses succeed with IT, he is spending time with his family and friends, golfing or snowboarding. So next up, we also have Tony Warner, a healthcare principal in CliftonLarsonAllen's Minneapolis office, with over 30 years of experience serving physician groups, hospitals, and systems by providing a unique combination of strategic operations, technology, and financial skills. Tony serves as an advisor to medical groups and hospital systems on a wide array of issues, including strategic planning, leadership and governance, mergers and acquisitions, compensation models, operations, and contract negotiations. He is called on frequently for revenue cycle and practice assessments, health information technology improvement, and macro assistance. Tony brings the ability to see the big picture while also understanding the details and implications of unique healthcare situations. And then last, but certainly not nearly the least, we have Larry Juergens, who is also a CLA principal, but based out of the Bellevue, Washington office. Larry has 25 years of healthcare experience and a diversified professional background in senior management and executive roles in healthcare operations, working with medical groups, ambulatory surgery centers, and hospital systems on operating improvements, strategic planning, and revenue cycle management. Larry exercises his Lean Six Sigma strategies, tools, and techniques to help, to healthcare operations in order to improve efficiencies, cultures, and reduce program costs. So without further ado here, I will turn the mics over to these three great professionals so they can address all of the intricacies around the Cures Act interoperability requirements. Gentlemen, go ahead and take it away there.
Thank you, Autumn. Appreciate it. I'm just going to introduce it first. Today, we've got a couple of learning objectives. Overall, Matt and Larry want to just really provide us with an overall understanding of the 21st Century Cures Act, and what it means to us as physician leaders, physician group leaders and those type of things. Gain an understanding about what's in there for relating to information blocking and interoperability and the opportunities that come from the interoperability standards that will be moving forward. So hopefully that'll help. As Autumn said, if you want to just kind of put questions in the chat box, we're going to try to hold those towards the end. And I'm going to turn it over to Matt and Larry, Larry's going to be kind of interviewing us on relating to that. That's going to be our format today. And with that, I'm going to turn it over to Matt and Larry to move forward with the presentation. And thank you, everyone.
Awesome. Yeah, thank you, Tony, and thank you everybody for attending. And we have, as Tony mentioned, some inserted pre-questions along the way. And so as you can see on your screen, I'm going to turn it over to Matt. And Matt, if you could just spend a little bit of time just giving us a little bit more information about True North and the area within healthcare, how you're working with your clients around the Cures Act.
Yeah, perfect. Thanks, gentlemen. Yeah, so True North, we've been around for about 20 years. My background is mainly in healthcare IT and cybersecurity, and we really have four modalities of the business. So we work in kind of the hosting of the electronic medical record realm, the cybersecurity realm, as well as kind of overall managed services. But one of the key kind of modalities of our business that relates to the Cures Act is working kind of in and around the data. And as we get into the Cures Act, you know, there's things like data extraction, data migrations, and then interoperability, which, you know, for those of you practice managers, that's usually called an interface. I'm sure you've heard the word interface 1,000 times. But really the interop side of it is quite a bit more than that. So across those modalities, we like to, per the prior slide, if you can step back, we like to really look at healthcare IT from kind of a maturity model perspective, and I'll tie this back. But when we work with healthcare groups, usually we go in and we peg the organization to one of these kind of levels. So typically we'll find most practices in that somewhere in between that reactive and proactive. They have a few problems, but they're not quite at the proactive range, kind of staying on top of their healthcare IT issues as it pertains to supporting the day-to-day physician tasks. And the way we do that, you can step forward in terms of the modalities of our business. These are very much a la carte and individual. So when we look at today's conversation, it really lands in this kind of application intelligence perspective in regards to, you know, more kind of in the data, in things like terms that you may hear like HL7, FHIR, which are some of the new kind of interoperability standards as it pertains to kind of connecting EMRs and ancillary EMR systems together. So when we, you can go forward. When you look at kind of how, you know, how we fit and differentiate ourselves into healthcare, you know, we've really kind of proceeded through the years, you know, from just a base IT consulting business. And as we move forward, you know, a lot of our customers needed more security, more offsite storage standards for HIPAA. And then as we've kind of progressed, you know, we've added more and more of these kind of data elements where we think there's a real valuable connection between kind of the clinical and financial views on healthcare data, as well as the kind of interaction with outside vendors and partners. So that would be, you know, kind of in the interoperability, which we see really expanding in the next, you know, 2 to 5 years. A lot of exciting innovations, you know, forthcoming. You can go forward. So, you know, some of our differentiators, we are healthcare IT, not only in the private practice side, but also the FQ and federally qualified health center side, and the community healthcare center side is a huge focus for us. All three of those kind of together, these are kind of the ways that we differentiate ourselves. We're solely focused on healthcare IT as it pertains to you know, the foundational kind of networking managed service side, all the way into kind of the data side, which is very different in how we kind of look at both the security from, the workstation side to the server side, but all the way into kind of the data side. And that gives us kind of the reach to both do remote and on-site work. We have a national reach and local presence, even in the Pennsylvania market. So we, where as needed, we staff and manage those dedicated staff under our team. But most of what we do is kind of remote. So.
Thank you, Matt. One thing I just would like to add, because you consistently understate the value that you bring to organizations in that. But the other part that I want to just point out is not only do you serve physician groups and things like that, you actually have EMR vendors and other providers, PACS companies and that ask you to host their entire cloud environment for them. And I think that makes, allows you to stand out in the level of service integrations and that you are able to provide in your service, and that integration that you're talking about, the interoperability. I think it really, that type of environment sets you different. So, anyway, I just wanted to add that because you didn't do it, but I think it's an important part of an understanding of why the expertise in security and interface and interoperability that you bring is important.
Perfect. All right, so let's start with the basics of the Cures Act. April 5th, we had our first kind of requirement going into effect, which is really around information blocking. So if you really look at the goal of what the legislation is trying to accomplish, is really to prevent clinicians, private and hospitals and payers from blocking access for patients to their data. And this is really exciting from where kind of we sit. I thought this would be kind of forthcoming, a decade or more ago. But the first step was we needed to get everyone on an electronic health record. So, it's rare you see a lot of net new kind of EMR purchases or implementations these days. You see a lot of kind of migrations. And really, we're just kind of, in my opinion, really getting started into kind of what we can do in healthcare kind of on data. There's been a lot of years and a lot of pushback, as probably many of you know. You just simply moving into the electronic record. It's not perfect, but it has gotten us kind of to this place, with some of those mandates. And now we're going a step further in really kind of expanding our access for patients and what data they can see in a more kind of expansive way. So the scope is pretty much all healthcare providers, partners, vendors, anyone that develops, interfaces with, or integrates with electronic patient health information. The impact is, let me go back one. The impact is really on everyone. The intent of this is to start putting some mandates around really firm mandates, and a lot of this you'll see in the hospital market, kind of in the Epic space and some of these larger EMRs, of really trying to force the opening of the integrations of APIs, which are application programming interfaces, based on some of the current HL7 requirements to share information between systems. And so, from a practice leader or physician leadership perspective, the impact that we're seeing is that while this definitely has multiple phases of deployment in terms of the way the Cures Act was written, everyone really needs to assess kind of their systems, ask their vendors, are we ready for this? and really understand what some of the exceptions are that, procedurally, to know what's allowed, what's not allowed, and make some kind of policy and procedure decisions, kind of in advance. Really with the tenet of, anything that would interfere, prevent, or discourage the access or exchange or use of EPHI. And that's really the intent of the legislation. And there's going to be challenges, but I think there's a lot of exciting things forthcoming as well.
Hey, Matt, you mentioned along the way here that there's deadlines coming up and there's lots of dates specific to how this gets implemented. So if you wouldn't mind just kind of, I think you have some slides here. Would you mind just going through and just give us a little bit more ideas around the timeline and implementation?
Yeah, absolutely. So as we kind of look through the different layers of this, and I won't go through every element, but the first piece of this, as it's kicked off, which was delayed due to COVID, as were many things, including e-prescribe and others, is really to start the to kind of kick things off on April 5th to say, do not block patient access to patient information. So this starts a series of things, including eligibility coming in July, but also it sets a foundation that can be followed for kind of a ticking clock for different vendors, mainly EMR vendors, as well as those that work in and around the electronic health record. And so what you'll see is a lot of, if you watch some of these EMR announcements, you'll see announcements around, service pack updates and upgrades and things that relate to FHIR, which is FHIR. If you haven't seen that, it's a new standard built on the HL7 principle for exchanging data. And really what we see, if you look at this grid, is they're kind of stepping into some really base things that start allowing the ability for systems to interact with each other. So they're basically stepping into the exposing of some of these elements, not all at once. Similar to how HIPAA was done. The enforcement of that took some time, which I suspect this will take some time as well. But it starts laying kind of a framework where there's some enforcement deadlines for those that create software, create tools, and work in and around the data, to really start marching down this list, which if you see here in terms of the compliance for API criteria, the rollout of the new API functionality, this is when we start getting access to broader sets of data as it pertains to sharing that with other providers for the benefit of the patient, but also so the patient can start having more control over their record and hopefully can make more informed decisions that, ideally, from my perspective, we start moving towards a more efficient, healthcare system where, given the access to data and the sharing of that information, we kind of eliminate some of the shortfalls that we see today.
That's awesome. When you and I were talking about this a while back, I think I had a basic question like, what is information blocking? And can you kind of walk us through what that is? And then, I think there's some other information coming along that as well.
Yeah, so, information blocking is really, it's really intended to prevent anyone that might limit either from the software side, meaning that the software vendor themselves needs to allow for the access to a record, if you're a provider, that could be part technical, that could be part procedural, and really the intent is to freely allow patients to have access to their record. So when you look at some of the HIEs and you look at some of the software vendors, I mentioned Epic before, but really when you look at the intent of this, Epic being kind of the elephant in the market, there's been a lot of pushback to kind of integrate in and around the hospital record, and it's been really perceived as a competitive threat. And I think the government has come in and said, look, you know, the patient needs to own their record, and for the benefit of the patient and their health, you know, we need to allow free flowing information and get outside of this competitive software realm. But it does go down into the procedural elements of the practice as well. There are some exceptions, so you know, we can get into some of those exceptions. But when I mentioned the procedural considerations, I'll give you a few examples here of the exceptions that are allowed. So with the interoperability and the kind of tenet to share patient information, there's always going to be procedural gaps, right? And so the goal is to kind of say, don't block the patient from getting their information, but at the same time, there are some exceptions, which I can go through a few examples. They've allowed for different stated exceptions to avoid fines and penalties, which I think are very good. And some of these would be preventing harm. An example of this would be a patient calls in, they want their lab result before the physician has a chance to interpret that lab result. So if the physician feels like, I don't want to release this information because I haven't had a chance to review this result, and I don't want to just send this raw data to the patient, maybe it's will create anxiety without clarification. There's a myriad of things which I'm sure you guys would relate to that the physician really needs to have eyes on before, which we know patients are going to call and be anxious about certain diagnosis. And so it allows the physician to have a little bit control there, and that's not considered blocking. But in all of these, if you're a practice manager or you're an operations person, you really, in my opinion, and this is some of the questions we're getting asked for, is, what is an exception, and procedurally, how do I train my staff to identify these things? Another example, a privacy exception, which I've worked working in the Children's Hospital here locally, that we dealt with quite frequently, is unfortunately abuse cases where the abusing parent is requesting access to the patient's record for a lot of different reasons at times, and procedurally, most of you probably have similar procedures in place to trying to tease out, maybe this is a separated couple, or there's a situation where that information needs to be kept private. There could be notes in the chart. So those are examples procedurally where you do not have to share information, but you really need to back that up with the policies and procedure. Security, if there's a security breach issue, potentially exposure of EPHI, those are also exceptions. If you don't know and can't authenticate the person requesting the information or the system, which relates to the healthcare IT performance side of it, the intent is not to slow down the healthcare IT kind of ecosystem. The intent is to actually improve it. So really all of these things, and even the infeasibility exception, that could also be financial in nature, tied to, the costs, right? So they're trying to balance kind of sharing of information, but they're leaving some room to, apply that to the different scenarios of the different specialties and practices. So what I'm encouraging our customers to do is really, look at their systems, look at their system readiness. Each practice and specialty is slightly different. There is a little bit of lead time here, with, the initial July. Most of the systems have the requirements met for July. I have not seen any that do not. That's been forthcoming, and with the delay of COVID, most of those integrated those. All the main electronic medical record vendors integrated those some time ago in preparation for a November date. But what I'm encouraging, the operators of the different practices to do is to look at these 8 exceptions and try to identify, are there any issues in our practice? Are there processes that we need to put in place when a patient requests information that we may not want to share that without X? So just trying to get ahead of that. It takes time to train staff, especially for those that are larger, and it may require a view into the healthcare IT system to identify what systems or tools are needed to even share certain pieces of information. And so I think that's the foresight of that, and starting to work now, similar to how HIPAA kind of transgressed, are very important things to do.
So Matt, can you go into the possible benefits for physician groups that are attending today, or as it relates to the interoperability, the requirements?
Yep, absolutely. So, with pushing forward kind of some of these requirements, there's some real benefits. I'm very excited about kind of, we've been kind of muddling with just getting EMRs implemented for a while. And the software isn't perfect, and there's day-to-day issues, I'm sure most of but I really believe that one of the reasons why we kind of sit here today is that the closed system without the ability to to have a defined standard really limits the choice and the innovation of the market and the practice. So with some of these new evolving data standards under the Cures Act, it really creates a lot more choice given the standards, because now all of these systems have to communicate on the same data standard. So you don't have a next gen standard, and you don't have an Allscript standard, and maybe a Athena or Epic standard. It's all based on the FHIR HL7 guidelines for exchanging information. And so what I believe we're going to see is that the choice that practices have for business benefit, but also the innovation in the market, will allow for, which many of you, I'm sure, going into software negotiations have dealt with, the conversation that's, you have to buy all 5 of these things. Maybe it's a portal or an interface engine, and all that is kind of inclusive, because they know that those systems won't integrate unless they're in their kind of ecosystem. And so I think what we're going to see is some vendor lock will be eliminated, and give us the ability to have a lot more choice. And I think we're going to see a lot more innovation on the types of tools we have access to look at data, to review that data, to share that quickly, as systems can talk to each other more efficiently. So in terms of kind of our recommendations, here's kind of the way that we're kind of looking at this. When I was talking about system readiness, our approach is always workflow first. we work in and around a lot of different vendors, consultants, and you can't you can't take some of these new standards and improve healthcare without understanding the benefits and how that kind of data kind of progresses through the workflow. You can't solve a lot of these problems unless you identify kind of the weak link of the data chain, so to speak, and really think through how that data flows, how it can benefit the practice's bottom line, which leads into kind of automation. So example, machines, meaning computers, are not going to replace all of your employees, but they're very key things we're doing in automation to improve reporting, to improve repetitive process, things like AR follow-up and other kind of other kind of views in processes where we can take something that's done over and over again. Even front desk, there's a lot of things that can be automated with some of the new technologies to really either focus labor in another area, or reduce the need for, we're seeing some practices that are expanding and having the ability to limit that kind of overhead by automating certain tasks. And the orchestration, the ability for different systems to communicate together and exchange data really in any format, benefits both the clinical and the financial sides of the practice. And so being able to sit between complex processes and orchestrate how that data is shared, how it's reported. There's a number of different things that allow for the orchestration of sending data, and the Cures Act is going to, in our view, be advantageous to do that. Simply because we can start exchanging clinical data with financial data in a way, and even outside systems. An example of this would be, some projects we're working on patient-reported outcomes. You can't get the readmission rate without being able to integrate in some of the other hospital systems for those of you that are private practice. And then really what we've started working on is the normalization. So we've started creating, instead of having EMR specific kind of data model, is a normal view based on the new Cures Act standards for fire. So we can start facilitating the exchange of EMR to EMR information, workflow information, as well as EMR to financial system integrations, which, in some cases, some systems are very efficient. But when you look at other ancillary systems, it's very limited to get the kind of views that, that I think are really required to not only bottom line views for the practice, but really, working to the intent of the Cures Act, which is really kind of a one-to-many, configuration where we can start using things like machine learning and artificial intelligence on the data to start looking at trends for not only quality, but also for the bottom line gain of the practice. Because I think I think those are very much linked to the HIP. Is we don't believe that physicians will see the value in some of this unless you start kind of looking at it from both sides. So how do we look at patient-reported outcomes using machine learning and identifying, our efficiency rating, to then go back to the payer and say, hey, we deserve another, 2% on our contract because our readmission rates are significantly lower than market average, right? So that's an example of taking that normalized data as part of the Cures Act in actually improving quality of care, but also keeping in mind the financial tie-outs, to each practice. So.
Hey, Matt, as we've looked through some of this, we've worked with quite a few groups, across the country also, and I think you're talking to a lot of the details around the around the back end stuff of this.
Mhm.
But we also see that a lot of groups, when you start using the terminology, talking about fire, talking about APIs, talking about the CARES Act or the Cures Act, excuse me, and those information blocking and the opportunities that come out of the ability to share the data and share data easily, that most of the physicians are unaware of it, that a lot of the groups, their education process that needs to happen internally is, to jump on your technology term, immature in that process. It's probably still at the chaos stage in that. And looking at that, can you give us, I've pulled up your first one, but give us a few examples of some real world things that you've seen as you go through, but also what are the things that really are going to be needed to really be prepared going forward with this.
Okay. Yeah, and these are lightweight examples. We're seeing a lot of different, a lot of these standards have already started in preparation for the Cures Act. So, a lot of the practices we work with, they don't even necessarily know about the act itself. A lot of them don't know about fire, the interoperability standards. They come to us with things like, in this case, we've moved EMR vendors. The new EMR vendor is a SaaS-based. We don't have the database kind of in-house anymore. And we used to have this process where we charge our patients an annual fee. It's kind of a hybrid on a concierge kind of medicine approach where they charge an annual fee for access to this particular pediatric group. And the request was, we used to do this in our old system, but now we're in this new hosted web-based system. This is very time consuming and painful, and we're going to have to keep our old system and sync that data, to maintain this billing process. So we were able to take the fire standards through the programming interfaces, which is a lot of this foundational stuff for the Cures Act, and actually make them a more automated and functional process for this billing process. So we go out every day, we look at new records, we pull that in and compare it, and then we automatically bill those customers, as their annual fees expire, which is in the EMR. So it allows us to archive their old EMR, so we no longer need to pay the old EMR vendor to support that old system. We've archived that, and then we've actually eliminated the need for a billing person to even look at this, because the whole process has been streamlined, kind of using what is going forward in interoperability. We're using the same standards, albeit lighter than what will be coming in the future. But what I was trying to highlight here is that, something that's not a clinical example, but it's actually a billing example that really does impact their bottom line in terms of, the practice performance and the avoidance of some of their staffing costs that they were seeing. So here's a totally different example using very similar kind of approach in kind of highlighting some of the benefits. So we're working with an ortho group in the South, and they had acquired some PT groups in their region, and what they were seeing was that they were getting some kind of leakage in kind of what they thought from their initial thesis. So they went out and acquired a PT group in the region, and their thesis was that by acquiring the PT group and keeping PT referrals kind of in-house in their own ecosystem, that it would be an additive benefit not only for their patients and use the current facilities, but they would also be able to improve their business by doing that. And that wasn't the case. They actually were not seeing the retention rates from these internal PT referrals. And so the question was, why is this, why is that the case? And so really, in terms of, and I apologize, the train is, we got an active conductor today. So after some research, a process was created to use machine learning and really start getting to, why that leakage occurred in the first place. And basically, in simple terms, what that means is taking a bunch of data, looking at, a patient that was referred internally and their demographic factors, where they live, to try to identify and improve workflows to maybe remind that person that, hey, we referred you internally. Maybe the patient education needs to be different because their demographic, and really get into some of the drivers in the practice that that could be procedurally modified to improve the bottom line benefits of keeping those referrals in-house.
Hey, Matt, I want to go off script here just a second, and I want to ask you a couple of you were talking about RCM before, but for example, my understanding is that as part of the interoperability standards and the fire standards and that, things like eligibility verification or in the future authorizations and that will all potentially be done much more efficiently using fire, and that there's a couple of them that ONC and CMS have already put in place to do that, the claim status and that. Can you just give us just one last, because we're up to the time that we should be at now letting questions come in. Can you just give us a little on your feel for that, how that's going to transform from the current flat file type transmissions into an API type transaction?
Yeah, so what we're seeing from our side is there's certainly there's a couple pieces. There's the EMR vendors themselves are integrating this, and the difference between a flat file transmission and some of the fire standards, the benefit is that historically the system would send out a actual file, like you would save a text file or a Word document, put it on a server, and then your interface engine would send that off, and hopefully it goes into a working interface system, and hopefully gives you a response back at some point. So when you're looking at authorizations and eligibility, when you look at FHIR, the benefit is that the system can talk in real time to the payer system, right? And so when you have someone sitting at the front desk, the system, the systems, and this is the leading edge of the Cures Act, right? If you're sitting there scheduling a patient, your EMR system or the third-party attached software to the EMR to allow the compliance, which is going to be common, will tell you right there as you're actually looking at their eligibility, or you're on the phone, or you need to authorize. The payers are required now to expose their systems so that the systems can talk in real time to make sure that the patient has the information that they need for the education on the actual procedure. And I think the intent is great, because when you go out and you go to the store, you can make an informed decision. But right now, if you want to go see what your actual cost is as a patient, you know, it goes into a very complex kind of ethereal process. And so the goal here is that this happens in real time. And what FHIR does is it actually goes out, checks a real system on the payer side, reports back, and then reports back to the end user of what that result is without having to wait for that information. So hugely beneficial. It's a small step, but I actually think it's a good one for patients to be educated about what things cost, and also to make decisions about the procedures that are best for them based on that. So
Thanks, Matt. Hey, so everybody, as we previously mentioned at the beginning, any types of questions, you could either unmute yourself, put it in the chat session, and we can just spend this time just making it trying to address anything that you specifically had. You know, I just wanted to ask Matt, in terms of, you know, if there was 3 to 5 things as a practice manager that I need to do like right now, what would they be?
yeah, I think, you know, first, you know, check with your EMR vendor. Most of these updates, I mean, we're doing a lot of these upgrades right now, for not only the Cures Act side, which includes some of the FHIR updates that, you know, are kind of embedded in every update that we're doing. But you know, I'm sure most of you are aware of the e-prescribe kind of mandates and integration, which kind of relates to that. A lot of the systems are bundling these together. So I think number one, I would ask, you know, just verify with your vendors that, you know, if there is a third-party tool or it's going to be native, you know, are they going to be able to meet the FHIR, you know, eligibility authorization standards, number one. I would say number two is start thinking about, you know, are there any exceptions that you could see in your practice? Every practice is different. Different specialties require, you know, handling of different diagnostic data differently. So, you know, I think some of that thought needs to go into to that in advance. You know, what scenarios would we say, you know, we're not going to share that information until X happens? I think that's, you know, a big one. And I would say number three really comes around, you know, kind of, you know, with these new standards, you know, what could we be doing that would, you know, help us reduce costs or integrate with information that, you know, improves us kind of as a business. And also that includes, you know, kind of differentiation, right? You know, if you're a private group and, you know, you're a private business, I would look at, you know, the ways that using access to data from not only your system, but the ability to use data from other systems to really differentiate yourself in the market where you can. You know, using demographic data, using some of the intelligent kind of analytics, you know, even in things like simple patient reminder touches, you know, looking at two systems together, you know, with the ability to access different layers of information, you know, that can be all additive to, you know, innovative ways. And we're seeing, you know, folks do that on our end. Things like encouraging a telemedicine visit for, you know, an annual, you know, annual health touch-in or check. Or it may be a reminder for, you know, a check-in or, you know, something that needs to be like a mammogram. We've seen that where there's reminders using the technology that's very simple stuff to do. And not only does it improve, you know, patient health, But from a business perspective, having the ability to talk across multiple systems is something that you used to have to kind of do manually, a lot of this stuff, and put manual processes. So those are the big three. Awesome. I really do think you need to balance. I think this is instead of looking at this as a legislative requirement, I think there's a lot of good that comes from this. But I think you have to put both your quality, healthcare quality hat on, and you have to put your business financial hat on to really leverage it. So.
Great. Well, I don't see any questions in the chat here, so perhaps just the next steps. I don't know if Haley, if you want to close this up, or there's our information on the screen there. And then of course this has been recorded, so I appreciate everyone participating.
Larry, I have to say, Matt, this is one of the quietest set of administrators. I was expecting we wouldn't be able to go through all of them. So I'd just like to encourage the group that's out there watching, if you have questions on it, I know that we went through a lot today, but potentially if you have questions, let's raise them now while we got Matt and Larry, the experts, on the line here, so that we can do those. And then if there are follow-ups, I'm sure that Haley, you'll get those to us, and we can get back to the group. But are there any questions before we transition here and end? Are there any questions that you have for our experts today? All right, Haley, we'll turn it back over to you. Or
I think, I think Haley's throwing it in my court here. But yeah, I guess I want to just thank, first of all, you guys, Matt, Larry, Tony, really appreciate your time today. And also thank you to all the attendees. Once again, feel free to jot down contact information for Larry, Matt, Tony. If you have any follow-up questions, either reach out to them directly or reach out to PAMGMA, and we can make sure that we get you guys connected. So thank you again. And, there's another session coming up here at 1. So everybody, please remember to log on for that. And otherwise, thank you all very much. And I hope you have a great rest of your week.
Thanks, everyone.